Hello, everyone. Heather Holmes here with KTV Fox 2 News in the San Francisco Bay Area. And joining me once again is Dr. Rashid Chotani. He is a COVID-19 researcher and infectious disease specialist. Doctor, thank you so much for being here. A lot of big developments today. I want to first start off with a vaccine and this timeline of potentially getting a vaccine by January. How realistic is that?
So thank you so much for having me. And it's a beautiful day out here in Virginia where I'm sitting. I hope it's a beautiful day there too. Uh, the the press conference that was held today, and when the president announced that we are going to have what he called the Operation Warp Speed project, and getting two very prominent people to head that is definitely a very good effort in the right direction. We need that in terms of the timeline. Well, vaccines are not developed and are efficacious. The studies cannot be done for safety and efficacy in the short period of time that was described today. Yes, we will have the vaccine. There's no question about it because manufacturing is ramping up before we actually have tested for the vaccine. So the number of vaccines that the president promised at the end of the year will be there. He had said that it's going to cost a lot of money. It's a very risky thing that they're doing. And I agree with them. It's a very risky thing. It's going to cost a lot of money. And we might not be able to use that vaccine because the studies might come back and say that this is not the best solution to the problem. However, out of the 100 vaccines that we had, we have about 14 now that are streamlined to be tested, maybe less than that, which is a very good number. But again, as I had explained previously, there are three phases to the vaccine development: phase one, phase two, and phase three. Phase one is when you have a small number of people in the study. Then you have maybe about 30 to 50 people. Then you have about 100 people. Then you have a very large number of people in phase three. What we've done is we're combining phase two and phase three together. But one of the things that we have to do, all the vaccine developers have to do, is to make sure that the vaccine is efficacious. That means when it is administered, after that, when you study, you find out that the person is now immune or has developed immunity to the disease, or is not going to get the disease. And it's never 100% efficacious, by the way. So even if we get a vaccine that's 60% efficacious, that's as good as any other vaccine like influenza, etc. But it is a difficult thing to have in the mix of how we can do that. The other thing is that we have to take a look at safety. Does the vaccine cause any serious adverse effects? And there have been, historically, if we go back, there are vaccines that have caused some serious adverse effects, and that causes a huge problem in terms of the trust in vaccine for the population. So we've got to be very cautious and careful. I honestly don't believe that by the end of the year, we will have a vaccine that is going to be in a while, or freeze-dried vaccine ready to be administered and to the masses. Meaning, I don't think we will have a vaccine campaign to vaccinate everybody in the United States at the end of the year. Yes, we could have, with the limited amount of vaccine that is going to be developed, that healthcare workers and frontline people might get that vaccine. So it will potentially be administered, but I don't think it's going to be a massive thing that's going to happen starting January. It will take a while before we have a real a vaccine. We need multiple, by the way, multiple vaccines, not just one vaccine, multiple vaccines so that we can, then be able to vaccinate the population. The best thing that came out of this whole interview for me was the commitment of the administration as well as the people who are running this operation, is that it will be available at a cost that is going to be affordable for almost everybody. And then whether it's China that's going to come out with a vaccine that is going to be developed first, or it's the United States or any other country, that data is going to be shared internationally, and everybody will be able to work together on this one. So for me, as I've always said, let's try to find a solution and work together. This was the best thing that came out. Again, I do not believe that we will have a mass vaccination campaign, and I hope I'm wrong, in January of next year or December of this year.
Okay, and Doctor, explain a little bit why you don't believe that we'll be able to meet that deadline for a mass campaign.
Because as I told you earlier, we have to really focus on a few things. We have to test. We have to be very, very careful in terms of the side effects. Plus, the manufacturing, which is being done right now, cannot be done at the scale of a failure that might happen at the end of the cycle. So yes, it might be available for healthcare providers. They might be enrolled in phase 3 studies, or they might be ones who would say that, listen, now the vaccine is available, we'll be okay in terms of you providing us the vaccine and testing it on us in phase 4, where you have the vaccine out in the market. But the timeline is just historical timelines that we've seen do not predict that a vaccine can be available at that particular moment in time by the end of this year.
Because there are just realities of coming up with a vaccine. There are hurdles that must be overcome that you cannot skip.
You cannot skip safety. Absolutely cannot skip safety. Safety is the most important thing, because what if the vaccine is causing some kind of a problem with the heart or the liver or some other organ in the body, and all those things have to be taken a look at. What if it's causing a reaction that is not the right thing to do? Now, if you go back in history, I mean, the best vaccine that we had is the oral polio vaccine. We still have it. But in the United States, we moved away from the oral polio vaccine to the injectable polio vaccine, because the oral polio vaccine was causing some disease in some of the children that it was being administered to. And that particular family, if one person was getting a problem with a vaccine, then that was 100% for them. Not a huge number in the big mix, but it is still a problem. So we just do not want to give away safety. We do not want to give away efficacy. That's why I'm saying that we have to have multiple vaccines, so that at the end of the game, we can appreciate what is the efficacy of each of those vaccines. And one of the vaccines might have a much better efficacy than the other one.
Okay, I want to move on to something else that we learned about today, and that is that some sailors have actually tested positive again, meaning they tested positive, they were in isolation after several days, some as long as 14 to 16 days, retested, and those tests came back positive again.
So this virus stuns me. I mean, it's just like a virus that we are learning so much about. We are, all the assumptions that we had in terms of how a virus reacts and how things happen just go out of the window when we talk about coronavirus. And it is just incredible. Not just that, as we talked about, there's an oral fecal transmission. We've talked about, Kawasaki disease that is being seen among the children. We've talked about the toes that, are seen, and, there's redness in the toes and all that we have observed. There's so many other things. The incubation period itself is in question right now as to how long that the virus can last. I mean, before you develop symptoms, is it 7 days? Is it 4 days? Is it 10 days? It might be a little longer. We don't know a lot. Now, on top of that, we have observed, and I have particularly observed in some of the cases that we've taken a look at, that in some cases the test comes out positive 14 days after you have, 14 days after quarantine. We have set a window right now that, if you have been exposed, you do the 10-day self-isolation. And then after that, if you don't have any fever or any symptoms, 3 days, then it's okay for you to go out and you're not infectious anymore. Now, in some cases, we've observed that people have IgM or even IgG, which should be positive, both of them positive for a longer period of time, as well as the PCR. Now, these sailors had the PCR test done, and the criteria that was put in place for them, like the criteria that most of the nursing homes have and most of the long-term facilities have for patients that are in the hospital, that once you have if you have developed COVID and confirmed COVID, you've got to have 2 negative samples, after which you can be admitted back to the nursing home or the long-term care facility. And it's just not happening. PCR is coming back positive. That means that the virus is still in the oral or nasopharyngeal space. That means that patient still has is potentially infectious and can cause disease to other people. So we are still learning. It is not the usual case, but in some cases that does happen. And we have seen that, and actually there's a case report that we had just finished where a person was PCR positive for over 16 days after the incubation, after the onset of symptoms. So it's rare, but it does happen.
So is this then pointing to the fact that this virus may live in our bodies longer than most, or is it that perhaps it could go, run its course through the body and then somehow you're exposed again, and then what does that say about immunity?
So there are two things. What you've asked are two questions. One is that does the virus survive 16 days after the onset of symptoms, and that could very well be true. We don't know how long it can survive. Further studies and further information as we gather, in some individuals it can last longer than other individuals. Majority of the people can, get rid of the virus in about 14 days. So that is something that we understand. Now, the second question was that if an individual was positive and then was isolated, how is it that they're positive again? Did they get exposed? If they didn't get exposed, to be honest about it, then there's absolutely no reason to feel that it was a reoccurrence of the disease. The disease was already there and it continues. Now, in many cases, what we've seen is, not many cases, a number of cases in China and other places, that an individual was positive, they turned negative. They developed IgG, which is a long-term antibody in the body after you get exposure, which means that you have immunity now, or some sort of immunity. And after a few weeks, they were again found to be positive for coronavirus because they were exposed now. So the exposure caused them to get the disease again. That's again a very rare thing. So as I said, this virus is just stunning everybody in terms of what it can do and how it can do things. And that is a critical thing that we've got to understand and appreciate. And that's why we've got to develop what I've always said, resilient communities. And we've got to be ready next year, or the next phase of this epidemic that it's going to probably hit the United States, as every expert has said. We've got to be ready for that. And if we don't have the vaccine, we've got to be ready with other things to deal with it.
Okay, so given all of that, what do you think of more and more states reopening? Obviously, there are risks associated with it, but now learning about the instance with the sailors, does it make you more concerned about reopening the economies?
So, there's always a concern in terms of reopening the economy. It's always a concern to, but to be, how long are we going to not open the economy? We've got to open the economy at some point. But what I always talk about is that we've got to make sure that we follow science and data and have a phase in, phase out policy. So we've got to take a look at what's happening in terms of the number of cases, in terms of number of cases that are turning positive versus the total number of tests being done. And we talked about that, the 10% kind of threshold mark, and going below that, achieving the 3% mark, where we feel that we would be much safer in terms of opening the economy and being able to handle any cases that come to the hospital, et cetera. And then obviously, if we are going to open the economy, we've got to have three things in place. We've got to have the testing, tracing, testing, tracking, and then tracing in place. So testing obviously is not in place right now. We have done about 10 in the United States. It's a very large number, but we've got very big population. So across the world, in terms of numbers, if we look at the graphs, per 1,000 patients, we are below many countries. We're even below Canada in terms of the testing that we've done. Although we've done a lot of testing, there's no question about it. In terms of if we look at the percent of positives and the testing done, we are way below the rest of the world. So we still have to ramp up testing. Once we've ramped up testing, then we have a much better handle of what's going on, so we can test people. If we come up with a testing device that is inexpensive, it's easy to use, and does not have tremendous amount of restrictions in terms of how to use it, then we can do serial testing of individuals and be able to understand what is really going on in the community. The saliva test that has just come out, which is a PCR-based test, coming out of Redford University. It's a home-based kit, but it's very limited right now, and it's not it's not in mass production. Once it's in mass production, it might be something that can help us understand and appreciate that. The second thing that we've got to do is we've got to have a very robust surveillance system, or different surveillance systems that are going to track as to what is going on in our communities, so that if there's a spike somewhere, we can go and catch it and be able to do something about it immediately. And then obviously, once we have that, we've got to have the tracking of everybody that has been exposed to the disease, and then follow up with them. And that is going to cost a tremendous amount of money in terms of for the healthcare departments and the county, state, and the local healthcare departments. And that is going to be in billions of dollars, because and some of that relief has been given to the local departments. Now, understand one thing, and that is that so far, even testing has been done by people such as National Guards or fire department and other government employees that are working over there. They can't do that anymore, because they've got to get back to work, right? Because if you're going to open the economy, who's going to? So now comes the question of who's going to do it. So there are so many requests for proposals out from all the different states, counties, et cetera, that they're looking at contractors to come in and do that work. And so that's the turnaround time on those RFPs, requests for proposals, was about a week. And so a lot of people are working, trying to get the pieces, in place to do that. Once that has been accomplished, because it's not going to be just so trivial that you can just open up a center for testing. You have to hire the people, you got to train them, and then you've got to maintain the quality control over there, and you got to do it for 3 months or 4 months, depending upon how much longer you want to continue the testing process. You've got to have the test kits available, you've got to have the swabs and reagents available, and that's another problem. So that is where what I call the Achilles heel of this problem. If we can handle, if we come up with a solution for that, then we can easily move forward. Then, of course, you've got to train the people who are going to do the epidemiology, the states. We need more people to do it now than the normal people that work over there. So we've got to hire more people to do all that work, and then have the people who are going to do the tracing of individuals that have been potentially exposed to a COVID positive patient, and then move forward. So you can imagine this is like a huge operation. And I was with the governor's staff today in the morning, the national governor's committee staff meeting, and I was telling them that what you've got to think about is you just can't think about giving all of this to for each county, each state. If you're going to have multiple people come in, multiple companies come in, do all that stuff, it's going to cause delays. So it has to be a comprehensive package that each of the individual companies are going to pitch to you, and then you will have to evaluate which is the best one to be able to go forward with this thing. Because if one company is doing tracking, the other one is doing testing, the other one is doing tracking, then the handoff is going to take time, and we just don't have time. For this thing to work, we've got to be fast and we've got to be accurate. And with all of that in place, we can still open the economy up, but we've got to have all these measures in place. And we are getting them. We get it, again, as I said, this is a complex problem, and we are looking at solutions, and these are the potential solutions that are there that we should be pushing and getting them done.
Yeah, as you mentioned, still an uphill battle in this. Dr. Chotani, always a pleasure. Thank you so much for helping us make sense of today's news surrounding the coronavirus.
My pleasure, and looking forward to seeing you again.
Thank you.